part is the expert comments. I think so you have already heard all the paper, and I like to only make few comments that the first paper, en bloc versus conventional. I think so the en bloc resection has become a standard of care, but only in selected patients, where the criteria has been already mentioned about 1 to 3 centimeter and mostly on the posterolateral wall of the bladder. If you do a large tumor, then there's a problem of how you evacuate those en bloc specimen. Then you have to again resect the tumor in the bladder or some other modality to remove. So selection of the case is very important, and feasibility and expertise of the surgeon is equally important. Comparison of sequentially gem doxy. The only comment I like to make that the BCG shortage has brought this concept of gem doxy, but now still I think so in India we have not that kind of problem of shortage of BCG. So we are still using the first line therapy as BCG, but the patient who are not tolerant to the BCG or compliant, then certainly you can shift over to the gem doxy. And our recommendation at present is the second line treatment. About the oncological outcome of short-term intensive chemo resection with mitomycin, I think so again here the problem is the follow-up and how you select the patient for these kind of procedures. The radical cystectomy versus trimodality therapy for muscle invasive bladder cancer. Again, I think so the counseling of the patient is very important, and we must give importance, explain to him the problems which are going to happen after surgery as well as radiotherapy. And if patient agrees according to their choice, I think so we should select. In this paper, they have not mentioned about the age factor. There may be a patient of 40 years of old and 70 years of old. Again, the choice of the patient may be different. So that's why all social factors, patient factor have to be considered before offering this therapy. And coming to the last paper about the same lymph node positivity role of radiation therapy. Here, I don't know how they have assessed the lymph node positivity in this patient, because when the study was done, I don't know PET CT was done or CT scan was done. So selection of the case again becomes very important, and counseling of the patient. Coming to these robot-assisted radical cystectomy with total intracorporeal versus open radical cystectomy. Again, here the important thing, if you are doing a total intracorporeal diversion, then there are advantage of doing robotically. If you are doing extraperitoneal diversion, then there is not much significant difference. But this is definitely a technically challenging operation. There are multiple steps in the operation, complications as mentioned, ureteral anosmosis and all that, and obesity of the patient, the comorbidities of the patient. So all these factors have to be seen together to decide whether you like to do open or, and last thing is the affordability. But the cost, as it has been mentioned already, in Europe, the cost is very high for even hospital stay, which is not the case in India. And now we have got the Indian robot also. I think so we need further studies to settle this better, which is the standard of care. And one is more primary chemoablation of low-grade upper tract urothelial tumor. The gel, we don't have that experience because this is not available in our country, but the concept is good. But the first thing is important, that how the primary treatment of the tumor has been done, whether they have done ureteroscopy, laser fulguration, PCN, or laser fulguration, what has been done, that has not been clearly mentioned. Or it has been tried only as a single modality treatment, we don't know after the biopsy. And last, we have already discussed. Anything else?
That's all. I think we should move on to the next.
You can take any comment.
If from the audience, any comments or questions?
Regarding the last paper which I was reading, I mean, it's very, absolutely right that we should look at the trimodal therapy. So muscle invasive bladder cancers, if we are not sure whether do you require a radical TUR to go and then do a chemotherapy, or you leave the tumor just to take a muscle biopsy and be, because there are times, or majority of times, we have patients who have got tumors which are more than half of the bladder involvement. Do you think you can give patient chemotherapy in a patient with such a large tumor? So that point needs to be done, that you have to have a two settings where you can do a radical TUR, be muscle invasive, give your results will different better. Whereas when you have a large tumor, you really cannot do a resection. And of course, this also brings in an issue of doing a partial cystectomy, which I've been debating for last 4 decades. I think these are the 3 points there.
No, one thing I will tell you that it is always better to do resection of the tumor as much as possible. I don't say you have to go out of the bladder to resect it, but it is if you want to have a good response, you should have good resection of the tumor, if possible, that radical TURBT. So we have done that also, and after that the outcome is better because the volume of the tumor is less. Yes, please.
Few points again in the last paper. The survival data of current day bladder tumor has changed a lot in the because of the new introduction of new medicines, all these things. So, and it was projected as a median survival, but the survival data, like overall survival rate, is significantly improved. So we cannot have a judgment based on these parameters because it's far better than earlier days. Then about the comparison, one is about clinically N1 node and a pathologically N1 node is entirely different. So in radiotherapy, we are assessing the clinical node, and in radical cystectomy will be a pathological node. We know that because of TURBT, inflammation, everything is going to be having a high false positive rate if you are assessing the clinically positive nodes. That is the inherent issue when we are taking or advising radiotherapy for a lymph node which is clinically positive.
One thing more, if you are using trimodality therapy or radiotherapy and chemotherapy, for these advanced cases also a regular follow-up is required. And they may ultimately end up with the salvage cystectomy. So when patient has to be told all these things beforehand, and then the cost of the treatment for coming for regular check cystoscopy and what is the standard follow-up, that has to be done in these cases. Moment you have done a radical cystectomy, at least patient is saved of all these kind of expenditure in future also.